have Lesa Williams, who is one of the doctoral students here at Rosen Hospital, who's been doing a great job teaching the diabetes at the community. So we will be having a short presentation on how she did the assessment of the diabetes patients here in the community, and how she incorporated the plan and the process for the community diabetes patients. So just sit back and enjoy the presentation. And we also have a guest here, Dr. Townsend, who is from CMS. He is with the Intelligent Group. Intelligent Group is a community quality improvement group from the CMS. So he is going to witness this program as well. What Lesa is going to be presenting. We have Miss Winnie Lewis, who is our Chief Nursing Officer. I would like to acknowledge her. She also will be present. And we are waiting on Dr. Faye. He is the medical director. Oh, there he is walking in, as I say. Dr. Faye is our medical director for the diabetes. I'm just introducing you to the team. And we have our lead dietitian, which is Brenda Beben. She is a key person who talks about all the diets for the diabetes patients here at our hospital, and also anytime we have the lunch and learn workshop. Of course, we have Phyllis Crenshaw, who is our case manager, who disposition the cases to the community when they get discharged from here. We have Sheila Martin, who is our educator for the hospital, who will be participating in most of hosting the
for allowing me to be here, and she's been my preceptor. She's also connected me with the fabulous Sheila Martin, who ran around the hospital with me for the first several months last year, learning about the hospital and everything. I wanted to thank my family. My husband is on his my sister and my daughter are right there. My dad is on his way. And my mentor, Dr. Elliott, she's not here today because she's interviewing in California for a job. So, and I know she's going to get it. So I want to thank everybody for coming today. As a doctoral student, I had to prepare a project, what's called a DMP project. And so what I did, I'm doing the extension of what Dr. Somi Nagaraj started. She developed the diabetes clinic. And so you guys here at Roseland needed a diabetes curriculum. And so, yeah, you can turn it.
Now this one is the line. It's there. It's there. Yeah, that one. Yeah, right. Okay.
So what I did is basically I developed and implemented a diabetes self-management education curriculum. So the purpose of this doctor of nursing practice project basically was to develop and implement an interdisciplinary diabetes education program for the outpatient from here in the Roseland community and for the people who come into Roseland Hospital. There's a huge lack of knowledge about diabetes and self-care, so that's that's the main purpose of developing this project. The objective was, again, to develop a self-management education curriculum that will be recognized by the American Diabetes Association. Now, being recognized by the American Diabetes Association means that Roseland will be reimbursed by CMS for everybody that they see. So, therefore, it's very important that this curriculum is approved by ADA. And just so everybody will know, I did write it according to the 12 standards from American Diabetes Association. So, diabetes in the Roseland community. This is data from 2008, but it is the most current. 14% of the adults above the age of 20 that's residing in Roseland have a diagnosis of diabetes type 2, 1, or pre-diabetes. That is a large amount. The national average for diabetes in the United States was 7%. What does that mean? That means right here in this small community is double the national average, okay? In 2010 and 2011, more than 700 residents of the Roseland community or hospitalized in different hospitals with the diagnosis of diabetes, regardless of which type. How was that data compiled? The zip code, 60628. And so I did a search of data catalog, and this is the most current from 2014. The need for diabetes education in the Roseman community, yes, there is a need. Right now, there is no formal program here at Roseman Community Hospital. So therefore, if a person has, an inpatient has diabetes, they receive diabetes education at the bedside, but there's no place here within the hospital for a person to be referred to. So therefore, they're referred to outside sources or resources. At the bedside initiate the diabetes education, there needs to be a resource right here to continue that resource, to capture that person and follow through. Dr. Already said that.
Somebody's at the door.
Okay, go ahead. Determining the need for diabetes self-management education here at Roseman. Somi, Dr. Nagraj, she's the CNO, Dr. Kave, who's the medical director, determined there was truly an unmet need for these residents within the community. And that unmet need was, there's so many people with diabetes, but there's nothing here. So the CNO, which is Somi, was Somi at the time, she's been promoted, expressed the need for formal diabetes self-management education curriculum and program. This gave me an route into the hospital with the CNO, the nurse educator, the nursing staff, the diabetic, the dietitian, and along with the case managers and the case workers. So therefore, I've worked closely with everybody over the last year to, they were referring patients to me, they were calling, saying, I have a patient. So that was unmet need, and I started the process of meeting the need. These are statistics from 2011. If you look at it, you will see that the number of people that visited Roseland Community Hospital emergency room with the primary diagnosis of diabetes was 1,300, over 1,300. How many inpatients were seen? Over 1,300. And how many were seen in the outpatient clinics with the primary diagnosis of diabetes? Over 900. That was in 2011. The next slide represents 2012. Now, look at the doubling of that number. 3,000, over 3,000 people in 2012 visited Roseland Community Hospital with a primary diagnosis of diabetes. Over 2,000 were admitted with the diagnosis of diabetes. And how many were seen in the outpatient clinic? Over 1,400. Those numbers are staggering, considering this is a small community hospital. I'm looking at my daughter's face. What is diabetes self-management education? Diabetes self-management education, I'm just going to read the definition, is defined as an ongoing process of facilitating the knowledge, skills, and ability necessary for diabetes self-care. In other words, you're diabetic, it's not going anywhere. This is what you need to do to take care of yourself. Diabetes self-management education incorporates needs of that person, that specific person, what goals they want to set, and their life experiences, okay? The overall objective of diabetes self-management education is to provide support for informed decision-making, self-care behaviors, problem-solving, and active collaboration with the healthcare team to improve clinical outcomes, health status, and quality of life. Now, that's for each individual. Each individual has to be able to make an informed decision. What do I need to do? I want to eat that German chocolate cake, and I want to have that milkshake with it. Not a wise choice. So therefore, it's self-care behaviors, problem solving, and active collaboration. The national economic impact of diabetes. Diabetes does not discriminate. It doesn't care about the race of the person, the sex of the person, or the socioeconomic status of the person. In 2012, the direct cost of treating and diagnosing a person with diabetes cost the U.S. economy over $176 billion. That's B-I-L-L-I-O-N. In 2012, the indirect cost of treating a person with diabetes was over $69 billion. Now, indirect is lost time from work, and things like that. Okay, sick time, lost time from work, and people being on disability. So that's indirect cost. So overall, in 2012, the total cost was approximately $245 billion to treat people in the United States with the diagnosis of diabetes. The effectiveness of diabetes self-management education. There are facts that diabetes self-management education does work. What does it do? It gives that person the knowledge they need to make informed decisions. So therefore, maintaining a blood glucose level within a normal range, it has resulted nationally in a 76% reduction in diabetic eye disorder, a 50% reduction in renal disease, a 60% reduction in diabetic neuropathy. So those numbers are huge when you look at the population, huge. The participants of the diabetes program here at Roseland, I had more than for the survey, I used 10 patients. I had a total of like 18 or 20, but I used 10 for the survey. So it was 8 females between the age of 32 to 65, 2 males between the age of 22 and 36. 2 of them had a college degree. All of them had a high school diploma. All of the participants were of African American descent, and all of the everybody resided within the greater Roseland community or surrounding community. The diabetes self-management education curriculum that I developed and implemented was a 5-week program, and it consists of week 1, what is diabetes? So I went over in detail with each participant, what is diabetes? We talked about diabetes type 1, we talked about diabetes type 2, and the majority of all of the participants were diabetes type 2, had diabetes type 2. And we also discussed pre-diabetes. We talked about complications of diabetes. And yes, some of the participants have complications related to diabetes right now. Some have the neuropathy in their feet. They're taking Neurontin for the neuropathy. Some have visual impairment. So, you know, some people are actually experiencing the complications. And, you know, as I was meeting patients here in the hospital, I saw a lot of people here on dialysis, young people on dialysis, young people with amputations of one or both extremities, young people, meaning under the age of 50, that was visually impaired because of diabetes. Week 3, we discussed survival skills and food basics and how to plan a healthy meal. We had fun during that week. Week 2 was traumatizing. Week 3, we ate. Okay. We did, in a couple of the classes, we made smoothies, and early on we made healthy snack bags. Brenda was in on that, and on the smoothies too. Then week 4, we went over the importance of medication. Everybody is on one form of medication or another. Usually a person that has diabetes, they are on some type of medication for to keep their blood sugar within a normal range. They're on something to control their blood pressure and at the same time to protect their kidneys. And then week 5, we went over living healthy with diabetes. And that one right there is where people, in my opinion, had that eureka, that light bulb moment, is not going away. I have to live with this. So at the end of each week, we would discuss a SMART goal. And a SMART goal is an acronym for specific, measurable, attainable, realistic, and timed. So at the end of each class, each participant came up with a SMART goal. And that goal could have been simple as, I'm going to walk, I'm going to drink more water, I'm going to call my doctor and make an appointment. And they did it. Everybody accomplished each week's goal. Okay. What is diabetes? Diabetes is a group of metabolic disorders that contribute to abnormally high blood glucose levels. Abnormally high blood glucose levels are often due to the body's inability to produce sufficient amount of insulin, the body cell's inability to respond and use insulin properly, or both. Diabetes is characterized by the pancreas' inability to produce or utilize insulin, which leads to abnormally high blood glucose levels. All of this information is from the American Diabetes Association. The common types of diabetes, type 1. This is the insulin based to that cell and be used for energy. If that sugar is high and it stays in the blood, it continues to go up and up and up, and then this person goes into diabetic ketoacidosis, which is a medical emergency, or what we also call hyperglycemia. So diabetes type 1 most often starts in children, but we have adults with diabetes type 1 also. Diabetes type 2 is non-insulin diabetes. Now, this person, their liver, their pancreas is still producing insulin, but the beta cells may not respond properly to the insulin. So therefore, they may be on a adjunctive therapy, meaning they may be on insulin and oral medication, or they may be on oral medication by itself, or they may be on diet control, okay? So this person is better off than the one with type 1 because they must take that insulin. And usually type 2 occurs in adults above the age of 18. Facts related to diabetes. In 2012, the Centers for Disease Control and Prevention, also known as the CDC, stated 29.1 million adults and children in the United States had a diagnosis of diabetes, whether it was diabetes type 1, type 2, or pre-diabetes. Now here's a staggering number. 8.1 million remain undiagnosed. Now, by the time a person has been diagnosed with diabetes, they've had it. They've had symptoms, but we ignore those symptoms. Your feet are numb and tingling. Visual impairment, dry mouth, drinking a lot of water, always hungry. Oh, I'm just hungry because I've been busy. Know the signs and symptoms of diabetes. 86 million people over the age of 20 had a diagnosis of pre-diabetes. That includes my sister. All right. Diabetes was the 7th leading cause of death in the United States in 2012. 7. Now, my conceptual model for developing the diabetes self-management education program was based on the health belief model. And the reason why I chose the health belief model is because it's based on each particular person, their perception of the disease and the disease process. And so a patient's perception of the disease and health is a key determinant on how that person will take care of themselves. When you look at people with diabetes, especially in the African American community, everybody in my family had it, so I'm gonna get it. My grandmother was on dialysis, so I know I'm gonna end up on dialysis. This is the perception simply because this is what they've seen. And so therefore, they're saying, my past is gonna be my reality. In actuality, it does not have to be. The health belief model is a psychological model that tries to predict and explain health behaviors. So the perception of anything is huge, especially when it comes to how a person is going to take care of themselves. This is a diagram of the health belief model You have the individual perception, you have modifying factors. Now, those modifying factors are huge. And then you have the likelihood of action. So when you look at the individual perception, the perceived susceptibility, the seriousness of the disease. So how serious is this? Okay, I have a hangnail, nothing is going to happen. And that's not a disease. But I have an infection, my skin intact. I need to do everything that I need to do to keep my blood sugar low or within a normal range. I need to keep my blood pressure within a normal range. So those are modifying factors: age, sex, ethnicity, personality, socioeconomics. Why is socioeconomics up there? What you can afford. If you're on Lantus and Lantus insulin costs $198 and you have no method of payment, you will not take that Lantus. So socioeconomic status is a modifying factor. Even when it comes to the oral medications, a lot of patients do not realize that some pharmacists give glucophage away free. Yes, it's free. Myers is one of them. So if a physician writes an order for glucophage or metformin, yes, it's on the $4 list at Walmart, but what if you don't have those $4? Okay. The perceived threat of the disease, that's a big one too. What is this disease going to do to me? Is it going to kill me? Is it going to cause me to be hooked up to a dialysis machine 3 days a week, 4 hours? I'm not going to be able to work, so it goes back up to the socioeconomics. Likelihood to take action, most likely, most people will take action based on the perceived threat. Okay. National hospitalizations due to diabetes-related complications, major. In 2010, heart attacks were 1.8 times higher among adults over the age of 20 with a diagnosis of diabetes than those who were not diagnosed with diabetes. 1.8 times higher. So a person with diabetes, it was almost a 2% chance that they were going to have a heart attack based on the fact that they had diabetes. Okay, when it comes to a stroke, 1.5 times higher. So if you have diabetes, yes, you're looking at having a stroke if the blood sugar is not controlled. So therefore, that is why it's essential to make sure people know how to take care of their diabetes. Again, diabetes is not going to go away. You can control it. It does not have to control you. Annually, more than 25% of patients with the diagnosis of diabetes was hospitalized for uncontrolled diabetes. 25%. That's a large number. Complications of diabetes, we already know. Uncontrolled or poorly controlled diabetes can affect every part of the body, leading to major complications. You have diabetic eye disease. The most common one, or the one that is exclusive to diabetes, is diabetic retinopathy. This leads to visual impairment, visual loss. Okay? It happens slowly, but it happens. Kidney failure. Think about the kidneys. The kidneys are designed to filter thin blood, not syrup. So when your blood sugar is high, your kidneys are trying to pump syrup through the body. And eventually the kidney's going to say, I give. And then you start going into kidney failure. Amputations. People with diabetes usually cannot feel their feet, or they have poor sensation in their feet. They stub their toe. 2 days later, they start feeling pain. By the time they go to the emergency room, amputation is required. Once the amputation starts, usually it's progressive. First the toe, then all of the toes, then the front of the foot, then the whole leg. It's usually a series. And periodontal disease. Remember, the mouth is already dirty, and sugar and bacteria, having high blood sugar gives a breeding ground for more bacteria, so therefore periodontal disease. People with diabetes are prone to other things: nerve disease, which is neuropathy, non-alcoholic fatty liver, hearing loss, and depression. So those are some things that people may be prone to. This is a picture or illustration of diabetic retinopathy. If you guys can see, the normal eye looks just, you see the blood vessels, but if you look over in the eye with diabetic retinopathy, you see all of those little spots or nodules. That is going to impair the vision. Eventually that person will lose their eyesight if they do not get it taken care of. This is that big old dialysis machine that people have to be hooked up to for 4 hours, 3 days a week. In 2011, diabetes was listed as the leading cause of kidney failure in 44% of all new cases. A total of over 200,000 people of all ages with kidney failure due to diabetes are living on dialysis or waiting for kidney transplant. Oh, here's something for shock value. This is a diabetic foot ulcer, okay? Is that gonna heal? Probably not, depending on what the blood sugar is. If the blood sugar stays up, those will not heal. Will it lead to amputation? Maybe yes, maybe no. Maybe yes, maybe no. But that is what a diabetic foot ulcer looks like, okay? This is periodontal disease. If you look at the top of the teeth, they're very red and inflamed. We eat with our mouth. More debris go between our teeth. Our blood sugar is high, so therefore it's a breeding ground for bacteria and tooth loss because of periodontal disease. The second week, as you can see, I'm going through each week and just hitting briefly on what we covered. So survival skills and food basics. Survival skills for a person with diabetes include knowing your targeted blood sugar, monitoring your blood sugar as prescribed by your healthcare provider, being aware of symptoms of abnormal blood sugar. Abnormal does not only mean high blood sugar. Abnormal could be low blood sugar too, okay? So think about it like this. If you have a blood sugar of 200 and someone has a blood sugar of 50, which person are you going to go to first to take care of? You got to get to that person with 50 because that 200 takes a while to come down. That 50 is going to continue to go down, and that is the person that is going to be unconscious. Making healthy food choices. We went over counting carbs and a lot of different things and reading labels. Brenda was very instrumental in teaching how to read the food labels and how to determine serving size. So therefore, that was a good thing. And moderate exercise. Some people feel that exercise means you got to get up and jog and do jumping jacks. That is not what that means. That means get up and move. Even if it's going up and down your stairs. If it means walking the hallway in your building. If it means walking from one end of the corner to the next, one end of your block to the next, that is exercising, okay? You don't have to do anything rigorous. Just get up and move. The importance of medication. People with diabetes are often prescribed several types of medications, statins, cardiac medications, and medications to control their glucose. Simply put, each medication has a specific purpose. Everybody who's on these medications, you need to always know the purpose of each medication. And whenever you're unsure, ask. Don't just take the medication because the doctor said it. Ask. Ask the doctor. Ask the pharmacist. Ask a nurse. All medication should be taken as prescribed by the healthcare provider. Do not change your medication dose. Don't change it. Each dose is specific and is that way for a reason. Living healthy with diabetes. This was the end of the, this was week 5. Living with diabetes, yes, it can be overwhelming. Each person with the help of others can take control of their diabetes and live a normal life by doing several things, keeping their blood sugar in a normal range. How are you going to do that? You're going to eat a healthy diet. How? Also, you're going to get regular exercise. It's recommended to have a dilated eye examination once a year. This helps to detect diabetic retinopathy. Have an annual dental exam. This helps to detect or see if there's any periodontal disease going on. And keeping the blood pressure, yes, blood pressure within a normal range. Why do you want to keep your blood pressure at normal range? The same reason you want to keep it in normal range for your kidneys. Your heart is supposed to pump thin liquids. It's not supposed to pump syrup. When it's thick, your heart has to work harder, and eventually the heart is going to say, I give, and you go into heart failure. I use the continuum of care trajectory for this diabetes project. The continuum of care trajectory for diabetes was selected because it asks specific knowledge-based and self-care questions. Each question on the questionnaire, each participant answered the questionnaire prior to starting the program, and they rated their knowledge on a scale of 1 to 10, and this was basically a pre-test. Upon completion of the 5-week program, the participants repeated the same questionnaire to rate their knowledge after they received their diabetes education. Go ahead. The continuum of care trajectory contains 23 questions that measures each participant's knowledge about diabetes, exercise habits, frequency of monitoring their blood sugar, taking their medication that's prescribed, their ability to cope with stress, and their ability to make healthy food choices. It was more than that, but those were the main ones when you look at the curriculum that was developed. Here are the outcomes. If you look at the blue, that is the lowest pre-test, and it was like 42. The highest was like pre-test was 118. After the treatment, which was the diabetes program, the 5-week program, the lowest went from 42 up to 120, and the 118 went up to 140. So it does show that the curriculum was effective, that the participants gained knowledge, and there was lifestyle modifications that went on there, or at least there was an increase in knowledge. Okay. Is there a need for a diabetes self-management education program at Roseland? Yes, there's a definite need. The most effective diabetes self-management education program are those that show behavioral changes instead of merely improving knowledge. So I would say all of the participants, they did something to change their behavior. Diabetes self-management education is effective to the point that it provides the patient with the knowledge required to avoid unhealthy behaviors and lessen the negative impact of their diabetes. Diabetes self-management education is known as an essential constituent of diabetes care. So it is necessary for a person to go to some type of formal diabetes program in order to go through each step. You can teach a small amount at the bedside, but once that person is out of the hospital, there needs to be a formal sit-down, one-to-one or group. The simplicity of this diabetes self-management curriculum, it was developed for the Roseland community, but because it's so simple, modifications can be made and it can be used anywhere in communities that are similar to Roseland and communities that are not similar to Roseland. And it can also be translated into different languages. However, since everybody had a high school diploma, we don't know if it can be used on a person that does not have a minimum of a high school education. But it's a very simple, easy to understand curriculum. Okay, now I have people who actually participated in the curriculum here, and I'm going to ask them to say something about what they learned and, just give a brief overview, about a minute. And I want to start with Ms. Edwards because she does have to leave. Introduce yourself.
I'm Willa Edwards. I just was diagnosed with diabetes. other things I'm going through right now. My son is a diabetic, he's on dialysis, goes 3 times a week. And I'm having to fill in where he can't, I do what I can do with helping him out and so forth and so on. But now he's in a state he has to have a kidney.
How was the program effective for you?
It makes me want to do what I'm supposed to do for one, because it really blows my mind too. Because I tell everybody, I call myself taking care of myself as far as things are concerned. I have worn a 3X at one point. And working with getting my weight down for one, that has really helped as far as what I'm doing now. Now I'm what, 10, what, something like that. But I would just eat, not fried stuff, but I can eat, I can't digest pork and beef at all, so I leave that alone. But grilled, broiled, baked, things like that, that's what I would do. But now I'm into diabetes, and I'm not people that eat really all day, but I'm finding I'm having to eat small meals, portions, and that drives me nuts.
Was the program effective for you? Did you learn anything?
I think, well, I'm kind of still learning because it's new to me. And what I didn't get was counting the carbs and all the different little things. I'm having to work with that. But I do try to be conscious of what I eat. And like I say now, I stay hungry a lot because I'm not eating a full meal. But I was told that I was going to have, 9 grapes and a half an apple. That's what they told me.
But what did I tell you to eat to help you stay full?
Right.
Protein.
They told me protein.
She wasn't eating anything protein based, and so that's why she was staying hungry.
Right. And so I would get nuts or different things like that, whatever would have protein in it. That does help, so I'm not as hungry as I normally would be.
Okay.
But I would say, just briefly, that the program was helpful to me. It's, you know, I'm still learning, but I see what my son is going through. I don't want to go through that.
Okay, thank you, Ms. Evans.
You're welcome. I do have to leave it to my baby.
Right.
I plan to return.
Thank you.
I gave a testimony
Yeah,
about the program. And
Elizabeth,
testimony is
thank you.
important.
Right.
And she organized it that way. It's
Yeah,
excellent.
I'm still
Thank you
learning.
very much.
You're
Thank you.
welcome.
Elizabeth Williams, she also participated. Ms. Williams, come on.
You didn't tell me I had to speak.
Excuse me. Before Miss Everett leaves, can she have a healthy meal and then
Yes, she
go?
can.
But she
Yes,
has
she can.
diabetes. I don't want her to skip a meal.
Right. Go ahead, grab yourself something.
I was like that though.
Okay.
Yeah, okay. I didn't want her to
That's why I
eat
look
empty
for
stomach.
something to eat. before I
Okay,
eat
okay.
in my mouth. But that's an idea though.
Okay, Ms. Williams, do you want to speak?
Hey, yeah. You know, I found out the program was very informal, was very beneficial to me. There were some things that I knew already because I've been a diabetic for over 10 years. One thing I make sure that, you know, because I have my annual eye check, because I'm too vain to go blind, or to lose a body part. So, but not having it under control, just doing what I well pleased, and it kept getting escalating until I took it serious that this can't happen to you. You know, if you not live what it lives, it's not going anywhere. So, maintain. So it was very educational for me because I don't want to lose body part. I don't want to have to go on to kidney dialysis. I don't even know. I don't want that. And besides, I feel better when I eat the right thing for the right reason. I've been on a high last couple of weeks because my blood sugar's been like 110. And it was, you know, it was high.
Yeah.
It was real high, but you know, it's flexible because I'm doing the right thing. So, yeah, it was very informative.
Okay, thank you. Geraldine? I'm sorry, Bernadine.
Hi, I'm Bernadine.
I'm sorry.
It was really helpful to me because before I even came to that, I had lost famous by diabetes, and it helped me a lot. Now I eat right, and my doctor is talking about taking me off the insulin. I take insulin twice a day, and she's talking about taking it off if I get my, you go take 80, 90 days, and I'm losing weight, you know what I'm saying? So I do the right things. I don't eat pork, I eat turkey. I basically boil all my food now. And it helped me a lot, learning about the diabetes. I wish we had kept the class going, because I like them.
Thank you.
We will, right, Dr. Cowie? We will continue with the classes going on. That's our medical director's vision, that we want to teach the community. We will be doing workshops, we will be continuing, we have CMS coming up with so many plans for our hospital, so we will be continuing, no doubt.
Okay, Ms. Pearson here, Ms. Dana, say a couple words.
Well, I learned a lot. I just got out the hospital 2 days ago for not listening. My sugar was going down, kept on going down.
And she has hypo, but she's done that.
So I learned a lot. Now I'm exercising, going to the gym, eating right.
Thank you. Okay, and our last participant, Ms. Linda Wilburn.
Hello, my name is Linda Wilburn, and I'm a diabetic. I'm insulin dependent, and I like a lot from the program due to my heart failure. I already have heart failure. I have a pacemaker. I have high blood pressure. Me and Miss
Williams.
I'll call you baby, first name.
Lesa, that's fine.
Me and Mr. Williams, we counted carbs, and Miss Brenda, we did smoothies. I brought fruit and vegetables. Miss Williams brought fruit and vegetables, and we had smoothies, which I learned how to add protein powder to my smoothies, and that makes it a meal, makes me full now. And then I eat my vegetables. I have spinach or kale in my smoothies, so they're always green.
Good,
And
very good.
I lost 10 pounds.
Awesome, that has to be applauded. That has to be applauded.
And
Promise.
I go to another group for my depression. It's called Grow, due to stress and regular problems that make me eat. I learned that I can have snacks. We had a snack bag,
Yeah,
and I don't have to
single
eat.
serving size.
I don't have to eat all of the family size Doritos. I can have a small bag where they sell them 2 for $1. I can have one. And I don't have to beat up on myself if I do wrong, or if my sugar is offbeat. I don't have to beat up on myself. I liquefy myself with water, plenty of water. Count calories, and I start all over again.
Thank you.
Thank
Okay.
you.
Okay, if you need a ride back, go ahead.
I don't need to grab that.
You don't need it?
This can take me back.
Okay. All right, who needs a, you need a ride back? All right, and I have 2 more people, and this diabetes affected my family personally. In 2013, my husband was in a hospital for 3 days with a diagnosis with diabetes. I'm gonna let him say a couple of words, and then my sister.
5 minutes.
Come, you need something, Lisa,
To
can
drop
you
the people.
do one drop food? He's waiting.
It's okay.
But she,
Go ahead, and
We're gonna get you a snack.
yeah, snack it first.
he said he's gonna wait. Okay.
Hi, my name is Anthony Graham. I guess I got real scared. I ended up going and I couldn't see. I was driving to work and I couldn't see, and called my wife and told her. She said come back home, but
Like he went to work.
I went to work and I made it, and I ended up in the hospital for, like you said, 3 days. What scared me most is needles. So I was scared to death of needles. When I left out the hospital, I was taking 4 shots a day. Today I don't take any.
Wow. Weight loss.
80-pound weight loss. The thing is you can control it, but do not have to control you. And I lost that from classes like this and my wife on my back. But it helps. I mean, you know,
Yes.
the thing I like to tell everybody, you know, is take the time and listen and pay attention. It's not a death sentence. You make it one. Right? Thanks.
Okay. And last person, my sister Brenda.
Take yourself.
No, I'm not going to take me. My name is Brenda Williams, and I was actually diagnosed pre-diabetic. It wasn't even actually a diagnosis.
It was 6.7.
Just about 2 years ago, but it did not materialize. But I would like to thank Somi for starting it, with Brenda, Sheila, and the rest for talking about having this clinic in here to help our community. We are fortunate that we have Ms. Williams over here volunteering her services to help us educate everybody in here, especially in the community. In fact, you don't need only the people in the community. I need doctors to get involved, because even doctors themselves doesn't know too much about it.
Right.
Doctors that are specializing in other field doesn't know how to take care of their diabetes.
Right.
And those are the reasons why we are trying to reach out to some of our doctors to come and attend and get themselves involved, so that they can also teach their patients how to take care of their diabetes and tell their patients about it. But we are lucky, we are fortunate that we have somebody now that will run our diabetic program, teach our people in the community and even doctors that are interested to join us. I would like to thank everybody for coming again. Hopefully, see, the first time I was here in 1974, we have a diabetic program over here. We have an educator, we have endocrinologist. After certain years, we lost our endocrinologist, we didn't have a program, so we don't have anything at all. It's up to some doctors and nurses who have patients enough to teach their patients how to take care of their diabetes. But I don't think it's enough. It's good, Ms. Williams is showing us all of this, and if we can show this to doctors too, they will be aware on really what to do with the self-education program for diabetic patients. So we are lucky that we have somebody in here now who keep on doing this. I don't know how often you would like to have this, but we try to reach out to the community and to the doctors about it.
Thank you, Dr. Howard. Now I request Dr. Townsend.
Well,
He
let
is
me
from
just say,
CMS.
Hold on for a second. Yes.
But I used to being a doctor, I'm a high-risk patient because I have a pacemaker and heart failure. And I would love for this program to continue on every 6 months, an evaluation like she's doing now of other people, you know, because my daughter, she's pregnant. And the doctor said that her sugar is going to be higher now because she's borderline diabetic. She's non-insulin dependent, but she's high risk. So I would love for this program to continue on, you know, even for other people.
Well, as long as we have somebody like Ms. Williams, Somi, and Brenda run this program, we'll keep on getting this program for everybody.
Good.
good evening. It's a pleasure to be here, and pleasure to meet you, the medical doctor in charge here, the chief. How CMS got involved is that our project was approved to move forward on a 5-year project looking at diabetes education in the DSME program. So we started in August. Just when you work with the feds, you get a manual this big telling you how you're supposed to do this. Like, get out of here. You get real. We got people need help. Well, we were able to drill through all that stuff and got to what we really need to do. And we identified certain communities that we have to work with, what we call disparate communities, especially in our African Americans, low socioeconomic communities. Roseland is very personal to me because my wife and her parents, my wife grew up in this area. And so, anyway, we started reaching out. and reached out to Dr. Somi here. And it was amazing how we connected back up, because we want to work in this community. This is one of the communities that we want to work with. We're going to be working in Inglewood with St. Bernard's. In fact, we signed an agreement today with them to provide DSME training to their outpatients in their diabetic area. So we'll be working, they do have an endocrinologist there, so we're going to be working with them. But it was right around, what, New Year's Day, or a couple days after New Year's Day?
Yes.
I called this lady because I heard what she was doing, you know, and very busy, but she took time and knew, I don't know, Christmas or whatever, I emailed her, and I said, Doc, you know, can we talk? I really want to, you know, get to know what you're doing, how we can maybe partner and help you. She called back a few days later. I was in the car, and she called, she says, God has really smiled on us today. She says, because we need your help. And I'm like, whoa, I almost let go of the steering wheel, because I was just as shocked. Our timing was everything, the right time, the right moment. And she told me about you, doctor. It's a done deal, that's a done deal. She told me about you and your work and what you were doing. And what she gave birth to this program, but she needed help and resources, you know. So, Doc, this is a moment that we could really make some things happen for this community. As our members mentioned, we need this. So, but we cannot do anything without your support. So just as you have some champions here, but they need help. And this project that we're talking about with Intelligent CMS is all about DSME. You know, and the numbers that Dr. Williams laid out here for you, it's real. I've been sleeping about these. It's real. It's real. It's so, and it's horrifying. What are we doing? So it's up to us to make it happen. So I thank you. I was supposed to be somewhere else today.
Yes, thank you.
But she sent me a letter inviting me to your presentation. And when I was meeting with her a couple of days ago, she gave me 20 minutes, the most precious time, to talk more about our project. And she says, you're not going to make it? I'm like, no, because I'm doing another presentation. And the look on her face was like, oh, you know, you're letting me down. So she's been on my mind all day, and you've been on my mind all day. So I was able to do what I had to do up there. I looked at my watch. I said, I'm out of here because I got to be at Roseland. So I'm glad I made it. I'm glad to meet you all and congratulate you for your efforts. And your words about taking charge of your life, that's the key. That's the key. So, but we got to do more of it. And we have an opportunity to demonstrate here. That's what, when you work with the feds, is all these projects and programs, it's demonstrated. And now, not only are you winning, but Roseland Community Hospital is now winning because we're making a difference. And so we have to tell our story. We got folks got money right around of us, be willing to write a check if they know what we're doing. So and when you're partnering with people like CMS, Intelligent, it says a lot about the medical profession and your team that you have with doctors and nutritionists. You know, I mean, so it's our time. It's our time. And I'm committed because I'm responsible for, you know, trying to hook this up and make it happen. And you got people who know what they're doing. So I'm committed. I'm glad I came. Now I can tell my gods that, you know, I do report to folks at Intelligent, but I can tell them what I witnessed today, and I can show them. And we, you know, and we got a reason why we need to be a part of this project. So I thank you all so much. And again, thanks.
Thank you.
Thank you.
So, I want to say something. First of all, I would like to congratulate Dr. Lesa Williams.
Yes.
Doctoral project isn't easy. Doctoral thesis isn't easy. It's easy to say DNP, doctor, but they got to jump through several hoops, and she has made it.
Yes.
And becoming a doctor is a lifetime achievement. And she made it. She did it. So I congratulate her wholeheartedly from the whole hospital.
Yeah.
So this diabetes envision for this hospital came into birth last year, 2013, when we, 2013, not 24, 2013, when we want to take care of this community. And I'm seeing God is showing us the way by collaborating and taking this to the next level. There is a saying in the Bible, I think you all would have read that. My people are destroyed because of lack of knowledge. Do you want, my people are perished, that's the word that's used, perished. Do you want that to happen to our community? Never. So here is what we are giving knowledge. Each one should teach one. So whatever knowledge you gain today, go and spread it out. Spread. You can teach one person out there, right?
Yes.
You can teach one person, maybe your sister, maybe your husband, maybe your daughter, somebody.
Yeah.
Teach them. This is diabetes, and this is what you got to do. Yes, Robin?
I have a question for Dr. Williams. Congratulations. So like as the healthcare system moves more into like preventative health, where do you see this DSM program and like reaching people before they reach the diabetic stage and like?
Well, I feel it should start in school. It should start in the school, at the school level. Children, not necessarily about diabetes, but about eating healthy, about exercising. And, you know, as they grow, they learn, and, you know, they may have a grandmother or a great-grandmother that's diabetic or have high blood pressure is up or something like that. You know, they can learn about that, and they can say, well, I learned that this does not have to be me. So this is what I have to do in order to not, their reality does not, their present does not have to be my reality. So I think it needs to start at the school level, and not high school, grammar school. Yeah.
Yes.
Yeah,
And
I
I would
think it
like
should
to-
be
yeah.
through the park districts and.
It should be a program coming up from the school level.
Right.
And I would like to thank especially Dr. Cowie, Dr. Thompson, Sheila, Brenda, all the dignitaries who came. And special thanks to all the patients who gave their testimonies. That's what I like to know. That made this workshop complete. Thank you once again.
Okay.
Okay?
We have food over here, healthy food.
Yes. Thank you.